Human beings assume we're the only people on Earth. Unfortunately, we aren't. There are millions of species on the surface of Earth. And most of the times, we make these decisions without even thinking of how these decisions Human beings assume we're the only people on Earth. Unfortunately, we aren't. There are millions of species on the surface of Earth. And most of the times, we make these decisions without even thinking of how these decisions we make affect every other thing in the ecosystem. My name is Tumsia Meimunaman Isa. I'm a veterinary doctor and an active field worker. AMR, this might sound new to a lot of people, but this is the looming pandemic that is about to hit, antimicrobial resistance. Have we wondered why we take drugs that we used to use years back and we quickly get better and we're back home? And then now you're using these drugs and they're not working. Some people will say NAFDAC are no longer doing their jobs. Some will say some of our brothers are producing substandard drugs. I'm not completely ruling out all those things, but have you asked yourself how you are contributing to this menace? So antimicrobial resistance basically means that the antimicrobials that are causing diseases, the bacteria, the fungi, the parasites, are now becoming resistant. And I like to use this phrase: what does not kill you makes you stronger. As a veterinarian, I will be speaking, of course, from the One Health approach, but mainly I will be speaking from the angle of the animal health. So most of our farmers are contributing immensely to this problem by misuse, underuse, and overuse of antibiotics. So these antibiotics have been produced, or should I say have been manufactured, to be used at a certain quantity over a certain period of time and for a specific reason. But unfortunately, here in Nigeria, a lot of poultry farmers are guilty of antibiotics abuse. For the slightest problem that is avoidable, they use antibiotics. Not just use it, they overuse it and they underuse it. As a veterinarian, this is a very concerning problem. Research in Nigeria has shown that most Nigerians are at the risk of consuming edible products, edible poultry products, fish products, other livestock products that contain high amounts of antimicrobial residue. And when I say high amount, we're talking about over 64% of this edible products contain antimicrobial residues. Scientists in Nigeria took the pain to conduct research just to prove and have a substantive evidence that these antimicrobial residues are present in poultry byproducts and other livestock products. Ekene Vivian Ezenduka, in her research, found a 64% prevalence rate of antimicrobial residues in poultry edible byproducts in Enugu metropolis. Jalaluddin Rabbana Lawal et al., in his research of antimicrobial residues as a potential public health hazard, found that a large populace of Nigerians are at a high risk of consuming edible poultry byproducts with antimicrobial residues in them. Let's listen to a story of someone who found out that an antibiotics wasn't working for her.
Hello, my name is Precious, and this is my AMR story. So I think in October, I got sick, and then I just went to the clinic. I think it was, my sister was scared I was actually worse. So when we got to the clinic, we just had malaria injection and then typhoid medicine. So I started taking the typhoid, the antibiotic, and then it was looking as if I was not getting better because I was supposed to take in the morning and in the evening. but I just wasn't getting better. My head was still aching. I could not really stand properly. So I had to take a break. I was advised to take a break, and then I started taking 1-1. I think about 2 weeks ago, I think a week ago, I felt sick again. And this was, I think, barely 2 weeks after I'd finished my medication. So we went to the hospital, did a blood count, and then it was said that my typhoid was very high, like 160. And I'd already taken antibiotics, so I think my body was not accepting that one. It was rejecting it. So what the doctor did was to give me Ciprotab. Ciprotab IV. So I had to take in the morning and in the evening for 2 days. And I'm better. There was no culture done because I already had an antibiotic in my system already. So I think I should actually go for a sensitivity test to be very sure of the antibiotic I should take next time. So I think it was partly my fault because I didn't really go into all the details and then do what I was supposed to do. So, but now that I know better, I know that my body can actually reject antibiotics. I don't know the cost, but I'll have to do a sensitivity test to know the one that works for me. And honestly, there is a antibiotic test that we can do, a sensitivity test that we can all do to know the antibiotic that works for each and every one of us. I will do mine, so please do yours. Thank you.
My dear animal owners, my dear farmers, do you know that you can reduce the use of antibiotics on your animals by adhering to strict sanitary and good hygienic practices? Giving clean and safe water to your animals, making sure the environment is clean, making sure their feed is free from microbes. Stay safe, stay clean, stay healthy.
When we talk of fishes and how to make them healthy. When we talk of dogs and pets all around and how to make them happy. All that comes to play is family. All that comes to mind is family. When we talk about to make a fun and how to make it grow. When we talk of everything, na family to know. Na family to know. Even as a family, my crops that know that we die. In education, we are the information, we are fair. Sensitization, we number one. Farm Alarm, providing health care for livestock owners and their livestock.
Hello. All right. Good afternoon, everyone. And I'll have to ask this question first. Who missed me? It's been a while. My name is Dr. Tumsia Memuna Manisa, and I'm the Community Engagement Manager for Farmalat. It might be a bit too early, but I would like to wish us a happy antimicrobial resistance week. And I'm happy that we're here as major stakeholders in this space. We're having this discussion, and we need to stop with the self-serving bias and be straight up and ask ourselves, how are we contributing to this menace? We might think we might be doing our jobs, but we need to sit down, introspect, and reflect to see how our actions are contributing to this looming horror. Yay, Dr. Inya, I miss you too. You see, Dr. Inya just confessed. So if there's anyone who missed me, you can as well say it. It's fine. All right, thank you very much. So I will just be taking us through the agenda so that we all have an idea of what, just as usual, for those who are our regulars, we need to do all of this. What do I even say? Anyways, don't worry. We need to do all of these things to just get everyone in the mood. So I would start sharing my screen and introduce us again to the topic, and then go straight on. So you're welcome to yet another Tekla session by Familat, of course, in partnership with ECHO, MDoc, Ashoka, Making More Health. These are all our partners, so you're welcome. So today we'll be talking about the irresponsible use. Can we go back, please? We'll be talking about the irresponsible use of antimicrobials on farms and the grave effect of public health, and the grave effect on public health. Who is to be blamed? So we need to get this thing straight. And let's stop throwing blames. Let us accept that we are doing something wrong, and how can we make it better so that the larger population can be better. We can have a healthy ecosystem. Next slide, please. So as I mentioned earlier, these are just a few logos of our sponsor, of our partners. We have MDoc, we have Boehringer Ingelheim, we have Making More Health, we have Ashoka. But today, this particular session, it's also in partnership with Cassia. And Cassia is also a pharmaceutical company who are majorly into production of pharmaceuticals, biologicals, and other health-related products. So this is the agenda, the introduction, which I'm already doing. And then I'll give a brief about Pharmalat and then Project Tekla. And then we would have Professor Junaidu Kabir from the prestigious Faculty of Veterinary Medicine, ABU Zaria. And ABU people, I'm only saying prestigious here because it's Prof. Junaidu. Before they'll come and start saying ABU and others, naturally ahead. Don't even come for me with that. And then we would have AIG Aishetu Baju, President Veterinary Council of Nigeria, to share an AMR story with us. One way or the other, like I said, we all need to introspect. We need to reflect, and think that there is one time that something like this happened, but we just kind of we just shushed it as if it was nothing. But giving it a good thought, you'd know that there's just something that is off. And then we'll have an open discussion for all participants, and Dr. Kayode will be moderating that session. And then we'd have our hub experts to just give us a few recommendations, share their thoughts on how we can manage this situation. And then, of course, announcements as usual, and then next step. So next slide, please. All right, just an overview. So the Tekla project is leveraging ECHO model, which stands on these 4 pillars. So we use video conference technology to leverage scarce healthcare resources. We're all here. Specialists sharing best practices with colleagues, case-based learning, and of course, continuous monitoring of the program outcomes. Next slide, please. All right, so please take note. Project Tekla Africa leverages the ECHO model, as I mentioned earlier. We collect registrations, participation, questions and answers, chats, comments, and poll responses for our programs. Your individual data will be kept confidential and handled by authorized personnel. This data may be used for reports, maps, communication, surveys, quality assurance, evaluation, research, and to inform new initiatives. This session is being recorded, and then, of course, it's being streamed live on all our social media platforms. And we will be sharing a PDF version of the slides after this session via the email you registered with. Next slide, please. Just a few tips. You can have your camera on. If there is need for you to, you can use the comment section to drop your questions. And then please keep your comments and your questions respectful. Everyone's point here is valid. So just a few of this, just kind of some classroom tips. All right, next slide. Like I said earlier, so this is also in partnership with Ashoka and Kessia, and we're talking about irresponsible use of antimicrobials on farms and the grave effect on public health. Who is to be blamed? Me? You? Let's find out. All right, next slide. Okay, just go back a little. I missed out on something. So as I said, I will just briefly be introducing Farm-Alert and Project Tekla. So Farm-Alert is an animal health social enterprise founded in 2019 with the primary mission of enabling easy access to affordable animal health care in underserved communities in Africa. Animal diseases are the leading cause of losses to livestock farmers and pet owners, accounting for over 70% of total damage. Unfortunately, the animal health system in Africa leaves little to be desired and goes a long way to adversely affect these farmers or pet owners, who are the lifeline of our local food system. At Farm-Alert, we have been able to combine our relevance as a major animal healthcare brand in the marketplace with our mission of ensuring the easy availability, accessibility, and affordability of these animal health products and services across the country. We partner with local animal health professionals, mainly veterinarians, who partner with these local farmers in building an inclusive system for sustainable animal health and disease prevention. We also foster a peer-to-peer network where access to regular animal health products, veterinary services, and pieces of training can be easily obtained, and learnings at various levels of farmers' interactions shared. In summary, we are enabling easy access to quality animal health across Nigeria and soon Africa. Our Tekla sessions are in partnership with the largest privately held animal health company in the world, Boehringer Ingelheim, and Ashoka, an organization designed to support social entrepreneurs using the Making More Health platform. With the help of MDoc, our execution partners, our Tekla sessions move knowledge rather than people by using digital technology like the video conferencing application we are currently using. It is our utmost desire that you will find these sessions both useful and inspiring in your various chosen areas of specialty. Once again, I warmly welcome you to our ever-growing animal health community, where we derive absolute pleasure in helping you win. Please enjoy the session. Thank you very much. So, and I'll proudly say that Farm-Alert is the only animal health brand that is leveraging the eco model. So this is a big win for us. So next slide. All right, as I mentioned at the beginning, we have Professor Junaidu as one of our hub experts alongside AIG Aishatu Baju, who will be sharing her AMR story. Feel free, if you have some you would also want to share, you can drop your comments. So I'll just briefly read out the profile of Professor Junaidu Kabir so that you know the quality of knowledge he will be sharing. So he trained at the Ahmadu Bello University as a doctor of veterinary medicine, and he has been working since 1991 in the Department of Veterinary Public Health and Preventive Medicine. He eventually earned a PhD, split site, ABU and University of Bristol, UK, and rose to the position of Professor of Veterinary Public Health. Professor Junaidu has taught undergraduate and postgraduate students in the faculties of veterinary medicine and life sciences, and also as an adjunct lecturer and external examiner in universities across Nigeria. In addition to teaching and research in ABU, Professor Junaidu was the head of Department Veterinary Public Health, director of the Center for Biotechnology Research and Training ABU, national consultant, epidemiologist, and national biosecurity project coordinator under the Food and Agricultural Organization Emergency Center for Transboundary Animal Diseases in Nigeria. He currently serves as the Dean, Faculty of Veterinary Medicine, ABU Zaria, Project Coordinator of the African Center of Excellence for Neglected Tropical Diseases and Forensic Biotechnology, ABU, member of the National One Health Technical Working Group for NCDC, member of the National Laboratory Technical Working Group of the Federal Ministry of Health. He's the co-chair of the National Antimicrobial Resistance Technical Working Group. He's also the co-chair of the AMR Community of Practice, chairman of ABU Veterinary Agriculture Complex, member of the Veterinary Council of Nigeria. He is a trained and accredited assessor of the Royal Society of Biology, United Kingdom, member of the West African Biorisk Management Network of Sandia National Laboratories, USA, and a certified professional on biorisk management by the International Federation of Biosafety Association. Wherever you're sitting now, I think Prof deserves a round of applause. Professor Junaidi, thank you so much for sparing out time, because I can only but imagine how busy your schedule is with all of this portfolio, but you're still here with us. Thank you very much. So we can have Prof come on. Okay, let me introduce our next hub expert is AIG Aisha Tubaju. I'm not sure I need to go around reading out her profile. I think the veterinary community, your profile has spoken for itself. You've done really well for us, and we appreciate you, ma'am. So after Prof, I will bring you up to also share your EMR story. But for now, we're going to be listening to Prof for the next 25 minutes. Thank you very much, sir. All right.
Tumsia, can you hear me?
Yes, sir, I can hear and see you loud and clear.
Okay. Good afternoon. I'm not very used to this platform. So I'm trying to open the document.
Okay, we can share your slide from this end, sir, if you're comfortable with it.
Okay, you can.
Yes, sir. All right.
Okay. Thank you very much for having me. Good afternoon, colleagues. I'm glad to be here to be discussing this subject. Permit me, I have modified the title of my talk slightly from the larger theme, but I think we can still talk about some of the remaining issues in the discussion forum. I've titled my presentation as Antimicrobial Use on Farms and the Twin Problem of Residues and Resistance. Because I don't want to, I think the blame game is slightly a political issue, but I prefer to talk from the technical point of view. So I hope we will be together. Antimicrobial resistance is not a new phenomenon. When Alexander Fleming accidentally discovered penicillin, he almost instantly realized that there could be the possibility of resistance, because in some of the clear zones of inhibition he saw on the plates, there were some discrete colonies of the same organism, which means there are some clones of the bacteria, same bacterial isolate, that has now changed from unable to tolerate the drug. And he clearly warned that if antibiotics don't get into the right hands, they will become a weapon. And Fleming has been vindicated today. We are facing a silent epidemic of antimicrobial resistance, and largely has to do with the fact that antibiotics got in the wrong hands, just as predicted by Fleming. Fleming got an award, a Nobel Prize, for discovering penicillin, and since then, antibiotics came into the foreplay in medical care, whether in human medicine or in veterinary medicine. Next slide, please. So, it is essential that we find strategies to guard against resistance. And these strategies span a whole range of activities involving multiple stakeholders. In fact, there's been a lot of concern whether even we in the laboratory testing for resistance are promoting resistance. Initially, it was a theoretical suggestion, but it is true that once you expose antimicrobial bacteria to antimicrobial agents, it is lethal to them. So they have to develop mechanisms to survive it. So the small ones, even we use in the laboratory in testing, may in itself cause the development of resistance. So, but what is most important is, can we get the antibiotic and the right concentration that for that particular patient will be effective? And that is why there is no ultimate test that will say forever that if we find this susceptibility in this organism, that forever it is going to be susceptible. And that demands for the continuous laboratory monitoring of resistance. Next slide, please. So today we are facing a global problem. Like I said, that is called the silent epidemic, because it is not like the kind of epidemic of plague or Ebola where people will be dying and there is closure of roads. Quite the contrary. This is a very insidious, subtle phenomena, and it is occurring all over the country and all over the world, in many countries. And the major problem that we are even facing is, before you realize, even if your healthcare system is up and doing, some other people, because of the freedom of travel and the rapidity with which human beings move across the world, people can go for medical treatment in other countries and pick clinical isolates that are resistant and bring into your healthcare setting. And that may possibly explain some of the very virulent clinical resistance we are seeing in some pathogens, where we know our clinical practice has not matured to the level of use of such antimicrobial agents. And again, the importance of those resistance seen in hospital is that they are not too far away. They can reach livestock population and vice versa. And that is why I don't want to go into the issue of the blame game. For in the 60s, after the Swan Committee report in the United Kingdom in 1969, the medical and veterinary sectors in the UK were started arguing really about what's the origin of resistance. Is this because of you people in animal health that are profusing using antibiotics? And the fingers were also pointing the other way. It may be that you people in human medicine are using antibiotics too much. But the story of resistance now is not about the origin. It's about the problem that we have at hand that we need to deal with. And that is now, it's not a question of blame. It's a question of all of us putting hands together to do it. So according to the Centers of Disease Control, currently, that's about 2019, 2020, maybe about 2 million cases of infections and death are occurring due to resistance. Estimate actually about 1.9 million. But the projection is that by 2050, we will have up to 10 million deaths due to antimicrobial resistance. Unless another new pathogen emerges, it may be the single most important global cause of death. And that is why it is a serious problem. Next slide. So this is just to illustrate how pathogens resistant to antimicrobials have been gradually emerging. It's just an illustration. And once they emerge, you can see the curve. It keeps going up. They keep spreading. Whether it's methicillin-resistant Staphylococcus aureus or vancomycin-resistant Enterococci or methicillin-resistant Staphylococcus epidermidis. And we can clearly see, in the case of an organism like Acinetobacter baumannii, 30 years ago, this organism is not clinically important at all. It is resistant, susceptible to all non-antimicrobial agents. But as of today, Acinetobacter baumannii is resistant to very many clinically important antimicrobial agents, and is an important clinical pathogen now. Next slide. So Eventually, this problem got into the mainstream media, and the popular media started carrying it as a threat to humanity as a whole. Very like this caption by BBC when it says that is what we are seeing about antimicrobial resistance is an apocalyptic warning. And there is some element of truth in that, because if we cannot have successful surgery because of resistance, if you cannot have successful cancer chemotherapy because of resistance, if you cannot treat common infections, including like problematic infections like tuberculosis due to resistance, then humanity will be in for it. And it will really be an apocalyptic warning. Next slide. Now, this is the same thing, Al Jazeera carrying the same story about the end of modern medicine. Next slide. Now, the scary part is that at some point, the struggle was let's develop new antimicrobial agents. And you can see from this chart that antimicrobial agents development has been slowing down. So we are really not having any new antimicrobials in the pipeline. And that's why it's saying the pipeline is drying up. The pharmaceutical industry is not keen on investing in development of new antibiotics. And simply because many in the course of development or clinical testing, you will discover that resistance has already emerged. An antibiotic therapy is something that ideally you take for 5 weeks, for 5 days, 7 days, and then hopefully you recover. So it doesn't, the kind of investments that goes into production of antimicrobial agents are not, maybe what will eventually accrue to the company may not be worth it. It's not like antihypertensive medication that people that are hypertensive will take for life, or antidepressants or such drugs. Antimicrobial agents, the moment resistance develops clinically, they will be abandoned. And so the pharmaceutical company will have to invest in the development of a new drug. And again, the realization that some bacteria are just inherently resistant to some drugs. So that means you can hardly find a drug that covers all infections that can be used for all purposes. Next slide. Now, yet still, the available antibiotics are profusely being used. The global consumption in animal food production in particular is a serious international issue now. Recently, the ministers under One Health platform from different countries met in Doha, as in November last year, and signed what is now referred to as Doha Declaration. And one of the provisions of the Doha Declaration is that we are going to have antimicrobial consumption by substantial amount, up to half, by the year 2030. Well, Nigeria has signed that document, which means that we have committed ourselves to doing that. And so we have a lot of things to work towards achieving, reducing consumption by up to 50% by year 2030. But all the same, the theoretical projections at the moment is that the consumption is going to increase. Unless, of course, with these declarations, we are going to do something fundamentally different that will reduce the consumption. And if you look at the consumption, we are consuming more in animal production than actually what is going into human health care. Perhaps it's because of the human population growth and the need to intensify production. I will see the pattern in different parts of the world, but absolutely the intensive production is being implicated in the rise in the total amount of antimicrobials consumed globally in animal production. Next slide. This is just to show you the trend. And if you see the projection, you see Nigeria towards the end referred to as NGA. These are the countries, the largest 5 consumers of antimicrobials in livestock in 2010, and the projected consumers and the ones that will grow. And you can see Nigeria is among the 5 countries predicted to increase consumption by well over 100%. And this is an important signal for us whether in the human medical sector or in the veterinary sector, to really wake up and do something about antimicrobial consumption in Nigeria. Next slide. Well, this is just to buttress the amount of the global consumption and the increased demand for animal products and the kind of rise. At the moment, we are witnessing something like 67% rise, and I said by 2030 it will be well over 100% increase in our current consumption. Next slide. I would like to thank Dr. Ndahi of Federal Ministry of Agriculture for providing this data. This is the on national data about antimicrobial importation from 2014 to 2021. And you can see that there are some categories of antimicrobials that in and out, but we consume a lot of them. Almost all the key classes are consumed in Nigeria. The only one that we don't have official data of their consumption or importation is nitroforans, although every practitioner in the country will tell you that nitroforans are available in the market and they are being used. But officially, these items are not allowed to be imported, and yet, because of our porous border, somehow they sneak into the country. Next slide. This is just an estimate of the total amount of consumption. You can see in 2014, 207,000 kilograms. By 2019, it's 654,000, over 654,000 kilograms of antimicrobials imported into the country. Next slide. Definitely, there is global concern and global oversight over the problem of resistance, and OIE has been one of the international agencies and the responsible agency for animal health advocating for responsible and prudent use of antibiotics in animal health, and the importance of these to both the animals themselves and their welfare, and the importance to food security and public health. I advise you, if the OIE has a special web page on the activities of antimicrobial resistance, so also does FAO and WHO. And these agencies are now together with UNEP working in a quadripartite to address the issue of antimicrobial resistance using the One Health approach. Next slide. So what happens that antimicrobial resistance keeps emerging? Although we don't have the data that quantifies exactly, we have this figure that how much we have imported, but we know that there is a discrepancy with what we are using and how much we are using and what is important. What imported is the country. Because we do have individuals that bring in drugs on their own. And what we have been able to research, at least through surveys and research in Nigerian universities and research system, is that we have a big problem. We still don't have a robust classification of over-the-counter drugs. What I mean by over-the-counter drugs, if you look at the veterinary, the compendium of drugs, what is that? The veterinary formulary. The veterinary formulary says antimicrobial agents are prescription drugs. But then antimicrobial agents in Nigeria for animal use really handled as prescription drugs. So there is a gap in terms of who is supposed to enforce and make sure that antimicrobial agents are prescription drugs. The second problem that is happening in Nigeria is we use cocktails of antibiotics, particularly in poultry production, and now into aquaculture. Even though recent meeting discussions with NAFDAC, they said that they have banned the importation of cocktail preparations. But almost immediately after that meeting, I took a little survey. I'll show you some of the data that still indicates that we have a lot of cocktail antibiotics. What I mean by cocktail, I'll give you a few examples. A situation where you have more than one antibiotic category class in a preparation that is intended to treat multiple infections, sometimes even in livestock and poultry. And sometimes you wonder the scientific basis for the combinations that are provided. You see ciprofloxacin with oxytetracycline with neomycin. I keep telling my students that it's like saying you enter, there's a person who is a Boko Haram in the market, and then you said, okay, what we'll do, let's station a machine gun and gun down everybody. In the process, hopefully, we'll gun down the Boko Haram member. That is almost the quantity of use of some of these preparations suggests that we are just intending in killing organisms indiscriminately. Thirdly, there is also the massive use of TLA. I remember in those days, the most lucrative job you can get as a graduate of veterinary medicine was to work for some pharmaceutical companies that will give you a car and there are cartons of drugs. And the most popular one was TLA. TLA has been very popular in the field in Nigeria since the 80s and is still continue to be clinically relevant. Whether it is as effective is a different question, but it is because of its long-acting nature, many clinicians favor it over several other drug preparations. And for this reason, it has become one of the major drugs of abuse in the country. We have serious failure to observe withdrawal period after using drugs. This is a professional negligence and as also the lack of regulations and ignorance on the part of consumers on the use of drugs. And I will discuss that further. There is also use by inappropriate persons. In several surveys, over 50% of farmers have responded to the fact that boldly that they use antimicrobials and they administer it themselves with or without prescription. And this is one of the areas we need to pay a lot of attention to. Next slide. This is just an example. I'm sorry, it is not intended to embarrass anybody, but it is one of those combinations. I don't know, I got it not long ago, but I don't know whether it's still in the market. It is also a drug that is a combination of oxycycline and neomycin, but I must say that this is not the only drug in the market. There are several of them that are combinations. Next slide. Now, the other issue is when we talk about antimicrobial resistance in animals, it is not the same as in human beings. What is important is the fact that whether antimicrobial resistance emerge in animal pathogens or in human pathogens, these bacteria are shed. And sometimes there are some bacteria, for example, Campylobacter in poultry. If it develops resistance, Campylobacter in poultry does not harm the birds. It's a commensal in birds. But if Campylobacter contaminates the carcasses and human beings get exposed, it causes serious illness in human beings. So this is why control of the drugs from the point of veterinary medicine is extremely important in public health. Because even though those pathogens may not be clinically important in veterinary medicine, they may be clinically important in human medicine, and they will have zoonotic transmission through the food chain. So again, it has been shown that the moment you begin to feed your chickens with particularly certain broad spectrum type of antibiotics, particularly the fluoroquinolones, they will begin to shed resistant Campylobacter. It looks like feeding the antimicrobials to the birds will increase their chances of shedding resistant organisms. And this has been shown in several studies, including in Salmonella. So the use of fluoroquinolones this has been shown the moment Bayer introduced rofloxacin, resistant to fluoroquinolones in poultry became a very big subject of discussion in Europe and subsequently in the world. Next slide. Then there are also situations where you have some organisms can be found as in some animal, for example, in some animal species, and those animal species constitute a reservoir of resistant pathogens to the society, to humans, and also to other livestock. For example, Enterococcus. Enterococcus in pigs. Pigs can become an important reservoir of resistant enterococci. And this has been shown to be more common in farms that use antibiotics. And that means the spread of vancomycin resistant strains from pigs to humans has been clinically proven as an important mechanism resistance transfer from animals to humans. There are many reports of humans getting infected from enterococci from pigs. Next slide. Now, if you look at the story of methicillin-resistant Staphylococcus aureus, which started as a nosocomial pathogen in few hospitals and then rapidly spread to other hospitals in Europe, they started closing hospitals because of MRSA. And subsequently, it became a community problem. People pick the infection from hospitals, come back home, and they're detected to have to be carrying the methicillin-resistant Staphylococcus aureus. And eventually, it got into livestock population and became an important cause of mastitis and other disease conditions, including skin infections in small animals and horses, and now back to the community through the handlers of those animals. And now methicillin-resistant Staphylococcus aureus, that was not a veterinary problem, has now gravitated from human hospitals and now has become a veterinary problem. And now we are feeding back the system as a zoonosis. Next slide. Now, this is just a small data from one of my students that studied methicillin-resistant Staphylococcus aureus in horses in Kaduna State. And you can see that there is a fair distribution among institutional horses, performance horses, rest horses, and traditional horses, those that are kept by local people and those that are used by the emirs and so on. So it means that methicillin-resistant Staphylococcus aureus is widespread in horses. And the same research showed that the same horse handlers are also exposed to these resistant pathogens. Next slide. Now, I said we are dealing with a twin problem, resistance and residues. They are not separable because if we use antimicrobial agents improperly in animals, we can cause sensitization of the bacteria and then we promote resistance. Similarly, if we use antimicrobials and we do not observe withdrawal period, they will result in residues. And those residues can also sensitize the gut flora of consumers and promote resistance. So they are intricately intertwined. Now, just to show you an example of the problem with regards to residues, because the same bad antibiotic use practice is resulting also in residues. And we can see this is also the data of a student, and just show that you remember chloramphenicol is banned for use in animal populations. And the study, this is in Federal Capital Territory, Abuja, and showed that people are using chloramphenicol. And when they were interviewed, they said, yes, they are using chloramphenicol. Out of 57 people surveyed, so 57 farmers, 5 were using chloramphenicol. And are they aware that chloramphenicol is banned? Majority of them don't know that chloramphenicol is banned for use in animal production. So we have a lot of job to do in the animal health sector. Now, not only is this thing banned, are they using human chloramphenicol? If they cannot find the veterinary chloramphenicol, now they go and get human chloramphenicol capsules and give the chickens. And next slide, please. And when we looked at, okay, is this problem now just in Abuja? And we took the information about where are these, well, this is in eggs actually. The survey was for chloramphenicol in eggs produced by poultry. So when we looked at the data, where are these eggs coming from? It looks like majority of the eggs supplied to Abuja are coming from mostly from the southwest, particularly Oyo State, where there's a high density of poultry. And this is the same eggs that were surveyed and were tested to be using. Some were coming from Niger, some from Zamfara, some from Kaduna, some from Plateau, and so on, and the states around the Federal Capital Territory. This is just an example to show that because of the complicated marketing systems in Nigeria, one state alone cannot control the problem. So it must be a national approach. And it's only this natural approach, because if one state controls the problem, they will receive products that still endanger public health from other locations, as indicated by this study, how Federal Capital Territory in particular becomes a concentration of drug eggs that are containing residues. Next slide. Okay, this is another example. If you say that the data I showed you about drug importation, colistin is not there. So if you speak with NAFTA, I will tell you, no, we don't allow colistin to be important, because colistin, according to WHO regulations, is supposed to be a conserved drug, only used in very peculiar situations. But we know that every practitioner in Nigeria in the veterinary sector will know that we are using colistin. Colistin is available. So we decided to just pick just one small area in Kaduna State to look at eggs again, because they're easier to sample. And we found it in market eggs and farm eggs. Market eggs come from many locations, like the ones, the data I just showed you from Abuja. And the farm eggs are from farms within the locality. And we found that both the market eggs and the farm eggs contain colistin. And the concentration of the colistin was high, above the acceptable daily limit for colistin intake. Next slide. Now, the same farms that are using colistin use exactly a whole range of cocktails, like I mentioned. As most of these trade names that you see are actually not one antibiotic, they're a combination. So again, the range, if you look at Keproseril, if you know what Keproseril contains, it's more than one antibiotic. Oxyfuravet, anywhere you see fura, it means it's a nitrofuran. And remember, I told you nitrofuran theoretically in Nigeria is banned, it's not being imported. So this is, I'm sure this is the picture across the country. This data is, although it's local, but I say it's translatable to several, is in agreement with several other studies from many researchers across Nigeria that show the widespread use of these cocktails and cocktails containing banned drugs. Next slide. So why should we be worried? When we use the antibiotics, whether residues are caused or no residues are not caused, there may be the possibility that some of these animals may be carrying the resistant pathogens, and we send them for slaughter. When they are slaughtered, their meat may be contaminated from their GIT. If you know how abattoirs, the slaughter process takes place. And so through meat, through eggs, through milk, we can also disseminate these resistant pathogens. In addition, what is also of importance now in surveillance for residues is also surveying for resistant genes. Because sometimes when resistant genes are shed into the environment, they have a long-term consequence on human health and again on animal health. Because resistant genes in the environment can end up being picked up by animal pathogens or human pathogens. And it is these resistant genes that actually encode the resistant mechanism that we see clinically important. So as much as we are worried about taking care of the pathogen in the animals, but we should also be worried about shedding the resistant genes into the environment. Next slide. So next slide. Now, I keep encouraging people to look at this paper. This is just a study they did in Chinese pig farms, because China is one of the countries that is profusely using antibiotics. We'll be almost close to them very soon. And they use huge amount of antimicrobials on pig farms. And when they did a study from slurries of those pig farms, they found that the slurries contain a lot of resistant genes. And those resistant genes are transmissible to a wide variety of clinically and environmentally important gram-positive and gram-negative bacteria, which means even the disposal of animal waste is important in the control of resistance. Next slide. So who is safe? Nobody is safe. This is just an illustration. George is a person Are we back? Hello, can you hear me?
You.
Can you hear me?
Yes, sir, we can hear you.
Okay. I don't
Yes,
know
sir.
what happened. The screen went off.
Yes,
Okay,
sir.
so this is just an illustration. This was published by CDC. It's just an illustration of whether a person picks a resistant pathogen in a hospital on admission. He gets back home, there is high chance that he can introduce that pathogen into the home, into the household, and eventually into the community. Or it may be a healthcare worker working in a hospital handling a patient with a resistant pathogen and subsequently bring back that to the family. And this family is also raising these animals, and maybe the animals that carry the pathogen, they can infect through their food or through their waste. They can infect people in a household, and that household person can end up in hospital. So it's a rolling cycle of infection between humans, animals, and the environment. And that is why the One Health approach is critical in the control of AMR. Next slide, please. So the zoonotic transmission can occur directly by acquiring the pathogen or by acquiring the resistant genes. And there are so many genetic mechanisms that have been identified by scientists that codes for resistant genes and their mechanism for transfer from one population of bacteria to another. Next slide. Okay, before I round up, it's important to talk about the control and prevention. We There are now international organizations, WHO, FAO, OIE, or World Animal Health Organization, have developed mechanisms to reduce antimicrobial use and prescription by classifying them. I will not go into the classification, but that classification is in order of priority of prescription to guide practitioners as what are the first line, front line antimicrobial agents, what are the next line antimicrobial agents, which ones should be discreetly used such that we will have some reserve of effective antimicrobial agents. And this classification must be accompanied by such a regulatory framework. In Nigeria, we have everything that it takes. We have a NAFDAC that is supposed to control importation and manufacture of the drugs. We have the Veterinary Council that is supposed to regulate the practitioners, and so on. So we have all these mechanisms in place. But these mechanisms must have a way of working together. And these stakeholders must work together not only on the basis of your level of education, but we must use our education to make effective changes at the level of the farmer. So I'll take a few minutes to look at this issue in detail. Next slide, please. Now, in solving AMR, sorry, please. AMR is a complicated public health problem. And it is going to be a long battle that is going to last several years, if not decades. It is going to be very similar to global warming. Because, like the global warming, countries that were busy polluting the world and getting rich are now the ones that are saying other people should slow down. And this is similar with anti-AMR. Uh, there are some drugs that we have never seen in drugs to treat our
Mm. Maybe it's just all right. Prof is, I guess, having issues with his network,
No,
but
I,
we'll have
I,
him back.
I can hear you now.
Coming back. Okay. Okay. Welcome,
Okay,
sir.
let me quickly rush and finish. So the goodness God. Are you with me? Are you with me?
Yes, sir. We can hear you, sir.
Okay. So for us to successfully control AMR and residues, like I said, they're a twin problem. We need regulations. We have the regulations. We need food safety practices because regulations are supposed to control importation, manufacture, and access. Who is authorized to have access to antimicrobials? And then the guidelines for professionals. I'm very happy that Nigeria has developed the guidelines now. And also those quality standards for food or other products. And also the regulations will provide for sanctions of defaulters. Then these food safety practices about what practitioners do in the field, observance of withdrawal period, inspection of products, screening and testing, and the professional issue, professional competence and capacity. And even the professionals need to keep improving their capacity. And that is why MR is supposed to be on a continuing education basis. The issue of rational use, guided use, how to guide farmers to use drugs, to train farmers on how to avoid using drugs and use other alternatives. And the issue, lastly, the issue of public awareness, because for a developing country like us, it is going to be the most effective strategy to completely sensitize the people. That will improve the demand capacity for people to demand for good quality service, good quality products, and also to be morally conscious of the problem of AMR and to practice hygiene so that they don't acquire infections from their animals and they don't transmit infection to their animals. And also we are able to protect the environment. Next slide. Now, in several countries, that is why I said public awareness is extremely important. And this I have said in many, many fora, that a lot of times when we use antibiotics, whether it's in human medicine or in veterinary medicine, is due to fear. We are trying to prevent infection that is not yet in place. Or we are afraid if we don't take the antimicrobial, things could deteriorate. I remember a farm I saw in Kano that every Friday they load the chickens with antibiotics so that they protect them over the weekend, which is crazy. So this concept of antibiotic cover is not peculiar to veterinary medicine. In human medicine, it's very common after surgery, whether it's required or not. Antimicrobials are widely prescribed. And there is a case study that I like telling people in Denmark. Next slide. Where they banned growth promoters and use of antimicrobial agents for for preventive purposes, and they started monitoring the occurrence of salmonella and campylobacter in poultry and pigs. And from the time those antibiotics were banned for use in these animal populations, the number of isolations from carcasses of resistance of contaminants that are resistant to antimicrobials or salmonella and campylobacter begin to decline, which means rather than helping ourselves by massively killing other bacteria, we just kill other bacteria to allow the even dangerous one to proliferate. So we're actually promoting, the more you use antibiotics, the more we create the selection pressure that will promote the dissemination of pathogens we don't want in our food supply. Next slide. So I strongly suggest that we strengthen the One World, One Health, the One Health approach. This is the surest way we can succeed in controlling AMR. We need to advocate, we need to communicate, we need to engage multiple stakeholder communication activity, and we need to continue to tell our government to support alternatives to antibiotics, because one of the greatest challenge you will have as a practitioner is you tell the farmer, don't use antibiotics. And I tell you, my birds will get sick or my animals will get sick, and tell him, no, don't use antibiotics. You have to tell him what to use if there is real threat. So we must advocate for improving vaccination and biosecurity, which is we reduce the amount of antibiotics we use, and really not only advocate but also promote the use of competitive exclusion cultures such as probiotics, and also invest in research in the alternatives to antimicrobial agents. So perhaps collectively we can reduce the quantum of use of antimicrobials and hopefully reduce antimicrobial resistance and residues occurrence in our food systems. So I'd like to stop here and thank you very much for listening.
Prof. All right, thank you so much for that wonderful and insightful presentation. And I hope you get better soon. I know you said you were down a couple of days back. I can still see there's still some signs here and there. Wishing you a quick recovery.
Thank you.
So thank you so much. So alongside your presentation, we're going to also have the AIG, the Veterinary Council of Nigeria's president, to share her AMR story. But before then, the backstage, if you can hear me, bring up the slides with the president's picture, and then we can have. I'll bring up Dr. Femi Kayode. No, you go back. Yes, you go back just before now, and I'll bring up Dr. Kayode Femi, CEO Farmalad, to introduce our next hub expert, and then we can hear her story, and then the room will be open for questions, comments, and also your thoughts. Thank you so much, Prof. I'm definitely going back to my house to read this document. It has a lot of information packed in it. All right, I think we're almost there. Yes, go back. Yes. All right, thank you very much. Dr. Kayode Femi, if you can hear me, you have the stage. Thank
All right,
you.
good. Thank you, Dr. Tumsia. Great job you're doing. Can you hear me?
Loud and clear.
Fantastic.
So I'm
All
going
right,
to
so I want
honeycomb
to.
this. I look better.
All right, so I think the media team will need to set me up
No
properly.
worries, sir. All right, sir. Go on.
All right, good. Thank you so much.
You're welcome.
Well, let me share a brief story on why this presentation is slightly personal. And we have also assembled a cocktail of people to help us out with it. AIG has been somebody we all admire and follow. Before I read out her portfolio, so one day she said she was supposed to go and induct some vet students in, was he in Jos? And apparently she could not make it. And I visited her before going to Jos to represent her. And I heard touching stories. Her grandson was in the hospital, and the grandson hadn't responded to the series of antibiotics that were given to him. So while we were there, still talking to her, another friend and brother of ours walked in also, Abdulaziz, and narrated the same story, right? That he almost lost his own daughter because antibiotics were not working for the daughter. And so today, before I introduce the Assistant Inspector General of Police to share our own perspective, guess what? I got in the doctors in those hospitals to share with us exactly what's happening. Is antibiotics working? You know, sometimes when you get human doctors to share with you what exactly is happening from their own perspective, from their own angle, and also hear why. After their brief conversation around how big or how loud is this AMR, then I will introduce AIG, and then we'll all come on stage and figure out. We will first of all find somebody to blame. We have to find somebody to blame. If we blame everybody, then it's easy to start solving the problem, right? Because the topic is, who are we going to blame? Are we going to blame the president of the veterinary council, who is in charge of the training and the practice of all veterinarians across the country? Are we going to blame Professor Junaidu, who trained us? By the way, he trained me as a vet, and he's one of those lecturers we admire in ABU. Are we going to blame the human doctor? Fortunately for us, we have them. We also have somebody, the Abdulaziz I mentioned is also on stage. Are we going to blame him for giving his children things that could make them resistant to antibiotics? So there's a lot of people. Are we going to blame Dr. Tumsia for not educating us strong and well enough? Maybe I will remove myself because I'm privileged to be the moderating, be in the moderating seat of today's conversation. So I will exclude myself. But by the way, it's going to be an interesting ride. If you have Dr. Abdul Salman Nuruddin, he's a consultant physician. Can you just bring him up? I'm going to introduce AIG shortly after he has spoken and Dr. Babatunde has spoken. So he's a consultant family physician, Trust Charitos Hospital, Trust Charitos, Dr. Abdul Salman Nuruddin. Can you turn on your video? I think it will be a lot better if we can see you. Can he please kindly turn on? And you can also bring up stage Dr. Babatunde. I think I saw him also. Any one of them. They are all human doctors working in the same hospital. Dr. Babatunde, you can bring both of them up, Dr. Babatunde and Dr. Fantastic. So let's take Dr. Babatunde first. We have a sledgehammer to blame somebody for the persistent AMR, right? But we will not start with that. I want you to give us a sense of how big is this problem. Do we have AMR as big as what we're thinking in human hospitals? Can you say hi? Let's be sure that we can hear you.
Okay, thank you very much.
Fantastic.
Can you hear me?
Yes, loud and clear.
Okay, awesome. Okay, so while we're waiting for Dr. Nuru, I will just say one or two things before exiting. So definitely antibiotic resistance is actually quite common, especially in human subjects. We have at times when you have somebody on admission or you're trying to treat somebody for an infective process and you run the cultures and sensitivity and you have multi-drug resistance, as in resistance to almost all the antibiotics that have been tested against. And some of them are usually not the low-grade antibiotics, but the high potency one. One of the things we think might be responsible for this again is the indiscriminate use of antibiotics generally, right? There is a very common, it is not uncommon that people treat malaria with antibiotics. Everybody has malaria and typhoid, as the case may be. So people say, oh, I went to a pharmacy, they said I had malaria, and so they gave me an anti-malaria, and they also gave me ciprofloxacin. And many times we try to ask, really, what are you doing with ciprofloxacin if what you had was malaria? And then there is just this overdiagnosis of typhoid fever. People assume that every time somebody has a headache or you've treated malaria and it doesn't resolve, then therefore they must have typhoid. And unfortunately, pharmacies will dispense, even laboratory. I mean, you would have lab centers dispensing based on cultures and all of that. And permit me to say, if I would, that the fact that you grow, the fact that you grow a microorganism from a culture does not necessarily mean that that microorganism is what is responsible for this patient's problems. Because sometimes you could have microorganisms that are supposed to be like normal flora of the body, right? And then sometimes you can even have contamination. Permit me to give you an example. I had a lady come in some time ago. She said she just went to the lab to run some investigation. So she did a high vaginal swab, and they found that there was a growth of Staphylococcus aureus that was sensitive to rocephin, ceftriaxone. So she had to the pharmacy and what she wanted me to do was to administer it. Okay. I did have to counsel her that really I think this is going to be a quite a wrong use, because number one, for all I care, that staphylococcus was probably picked from your skin. We don't have any symptoms per se that we're treating, but I'm just saying that this is what people do. Okay, people have, when you have things like upper respiratory tract infections, many of them are viral in origin, but almost all of them get treated with antibiotics in many of our health organizations. So I think these are just some of the things that contribute. But to answer your question once again, absolutely, absolutely, there is a great core of antimicrobial resistance. Yeah, thank you.
All right. So before you leave, thank you so much for this. On a scale of 1 to 10, how big is this problem? If 1 is insignificant and 10 is alarming, on the scale of 1 to 10, what do you think?
So if you are not, if what you are asking for is not the prevalence, if you are saying at how, are you talking of how alarming it is,
Yep, yep.
or how prevalent is it?
Okay, let's first of all use the word prevalence. How common is this? And then how worried should we be?
Okay, so I would say in terms of being common, I would give it like a 50%. How worried should we be? I'll give an 80-90%.
So 1 in every 2 person that visit your hospital has a problem with AMR. Will I be correct to say that?
To a reasonable extent. Well, not only here, but I mean generally, just reviewing a number of cases. Yeah. So generally, I would say 1 in every 2. Yeah.
Then that's worrisome. I see Dr. Nuruddin coming in and out. So maybe before we eventually bring in Dr. Nuruddin, let's ask specifically, right? Do you think there's a connection between what we do as vets on farms and what you do as a physician, human doctor in your hospital? Do you think there's an AMR connection between what both of us
I mean,
do?
so definitely, you treat the animals we eat, right? And so definitely, if they are exposed to antibiotics and before the humans eat, of course, the humans might also consume that and could create some level of resistance. So that would be my response. So I would say yes.
Yep. All right. So is Dr. Nuruddin up now? I wish you would be able to stay around a little bit so that we can attend to a few questions here and there. Oh, fantastic. So,
Okay, Dr. Nuri is around. Oh, Dr. Nuri is around. Okay.
Hello, good afternoon. Can you hear me, please?
Yes, but we cannot see you.
Oh, okay, all right. Can you see me
All right.
now?
Yep, exactly.
All right.
So let's get a sense of view of what's happening from your practice.
Yeah, thank you very much. Basically, antimicrobial in general, and specifically antibiotic resistance is actually a very big problem. I listened to some part of the prof lecture, and also with what Dr. Babatunde um, said. Sometimes we see patients come to the hospital with infections, particularly bacterial infections, and we discover that from the beginning they carry resistant bacteria either in their throat or in their urinary tract or other part of the body, and this is actually quite worrisome. I'm aware that in veterinary practice, the prescribers are also the dispensers. We I'm not aware you have like veterinary pharmacists that prescribe that dispense drugs, and there's little bit of indiscriminate use of antibiotics. Some in some cases, human antibiotics are basically used mainly used in human medicine, are used in veterinary medical practice, and this predisposes the animals to resistance. And in some cases, like eggs, for instance, if you touch the eggs, you are preparing food, and you touch the eggs, and then you touch your mouth, your nose, and then you can transfer actually can actually transfer infections, especially in children. So this is actually quite worrisome. But what I want us to know, there's what we call antimicrobial stewardship, which everybody should know. Um, it's not an established program in many places in on our own practice, and it's something we should try and advocate for and establish a team that advocate for antimicrobial stewardship, whereby prescribers actually have information on evidence-based evidence-based information, evidence-based guidelines, and this guide them to prescribe antibiotics that the either the animals or the in human medicine the patient require for treatment, and then also indiscriminate use of other antimicrobials apart from antibiotics. And then for the human medical practice, um, it's quite challenging, though. We can't say that, just like Prof said, the issue of antimicrobial resistance is antibiotic resistance is the blame is from either the human medical practitioners or the veterinary medical practitioners. For me, a huge chunk of the problem is also from the human medical practices. Just like Babatunde said, there's overdiagnosis of some infections, particularly typhoid, not only typhoid, upper respiratory tract infections, infections that naturally do not require antibiotics. In some cases, patients request for those antibiotics, or we are forced to prescribe those antibiotics to patients, and which are not needed. And then um, antibiotics are not actually used according to plan. Sometimes patient you prescribe antibiotics for maybe like a week, the patient uses for 2 days and then discard them. Or sometimes you prescribe antibiotics for 5 days and the person can use it for up to 2 weeks. The person comes to the hospital, are you still using this drug? Yes, I'm still using this drug. So these are problems. And then I also believe that in the laboratory there are errors, pre-analytical, analytical, and post-analytical errors that give us false information about the sensitivity pattern of antibiotics. So sometimes the laboratory will be telling you about some organisms which are resistant to particular antibiotics, but clinically it is not so. So the only way we can avoid these problems is to stick to guidelines, which we don't most times don't use. I've had to several times, not only antibiotics, to emphasize to junior colleagues that you have to use guidelines. You know, Nigeria is a developing country. Most times, we use guidelines from abroad. So we use these guidelines to guide your prescription patterns so that you don't overprescribe or underprescribe. For instance, a case was recently a colleague of mine was a patient had a simple condition that did not require antibiotics. It was not even an infection, and the person was treating typhoid. So, and this leads to a lot of pressure on that selection pressure on that, but leading to resistance, especially medications, broad spectrum antibiotics like ciprofloxacin and so forth. So, in short, in summary, we have to establish a very good program on antimicrobial, not antibiotic, antimicrobial stewardship, both in the veterinary medical practice and human medical practice, with regular monitoring. And this will what will help in stemming the tide of resistance in microbial organisms. Thank you very much.
All right. Thank
All
you,
right.
Dr.
Thank you,
Nuruddin.
Dr. Nuruddin.
Why is it echoing? Back end, I'm echoing. I need to figure out why. All right, good. I think I'm good now. So, Dr. Nuruddin, please, before you run away, somebody back end. Just a moment. So back end, you need to help me figure out why I'm echoing. Am I good now? All right, so I think I'm good. Thank you. All right, so I want to ask Dr. Babatunde, not Dr. Babatunde now, Dr. Nuruddin. So I've asked this same question from Dr. Nuruddin. On the scale of 1 to 10, how prevalent is AMI? And how much should we be worried?
Well, yes, I will a little bit disagree with the Dr. Babatunde. I don't think it is that. It's up to 50%. I will give it like around 20-25%. 20 to 25% actually. It actually depends on where you are practicing. If you are practicing in a larger hospital, is different. The literature or the experience, what you come across is actually different from when you're practicing in a smaller place. In a place where there's an established antimicrobial stewardship, we don't see resistance patterns or frequency, unlike places where you don't have antimicrobial stewardship fully established. So I will give it 20-25%. When it comes to certain infections, for instance, let me say pharyngitis, tonsillitis, upper respiratory tract infections, actually. In bigger hospitals, you might not see much resistance as in smaller hospitals. And the resistance pattern will also differ when you go to, when you work in more remote areas. Remote areas, they don't have access to the high quality or the high potency antibiotics that are available in hospitals located in the cities. So it depends on the area you're practicing, the context of practice. So it's not, we should be worried, right? We should be worried, but I don't think it's as high as 50%. Otherwise, we may not, most of our antibiotics will not be useful. All right.
You know, when I was growing up, I'm still having this. I think you have two devices, Dr. Nuruddin. You have two devices.
No, I have only one device.
Okay, so we need to figure out what's happening.
I can see myself twice, 2 times.
So maybe that's where the issue is coming from. So back end, if you can remove one of his face, and let's leave the other one up. Or you can just take him behind while we figure this out, and then we'll bring in AIG, then we can bring him back up. Fantastic. All right, you know, when I was growing up, my dad, even up till now, he has the temptation to do that. When you get home and you tell him you are not feeling fine, he touches your forehead this way and said you are having malaria. You know, I don't know where he got that technique from, but he knows when it is malaria and when it is typhoid. And he will give you a cocktail. He's a mechanical engineer, so he repairs cars, right? But he will give you a cocktail of antibiotics to use and say, if you use this, that it will go away. I guess that's one of the big issues that we are combating in Nigeria, the misuse and the appropriation of antibiotics. But so let's bring in, we'll now start driving everything home, but let's bring in the president of the Veterinary Council. If you will, can you just help me bring her upstage while I read a few background about her? She has a lengthy profile. But again, she's somebody we're very proud of. Get to hear her talk. So AIG Aishatu Abubakar Badu, she was born 10th July to a Am I back up? All right, good. So, and from her birth to where she is now, she has attained quite a handful of feats, and she has been, just a moment, let me bring out. So for her education, she attended Gombe Primary School between 1975 and 1981. Her working career, on graduation from ABU Zaria, Dr. Aisha Abubakar did a national service with the Nigerian Police Force between 1994 to 1995, where she got over her fears for the police and fell in love with the job thereafter. Right now, she's occupying a position, an enviable position of the Assistant Inspector General of Police. She has been first female in a lot of things, first female Monitor General in the prestigious National Institute for Policy and Strategic Studies. And currently, she's occupying a very good position as the president of the Veterinary Council. And she has brought in quite a handful of transformation to the Veterinary Council. Please, if you will, I want you to help me bring up stage the Assistant Inspector General of Police, the President of the Veterinary Council, AIG Aishatu Abubakar, to give us her own side of the AMR story. After her own side, we will bring everybody back up, including Professor Junaidu, and then we will now start dissecting where is the blame, what should we do, and how should we resolve these very dangerous trends in terms of AMR, and how can we help from farm to fork to reduce this scourge. Madam President, ma'am, your video is not on. And your mic also is not up. Fantastic. Fantastic.
So you can see me and you can hear me.
Yes, loud and clear, ma'am.
Thank you.
Yes, ma'am. So we're looking for who to blame.
Okay, well, thank you very much for having me once again, Femi. Professor Junaidu, sir, he said he was your teacher. He was also my teacher. So, and a senior colleague. So, and he has been doing a lot of work on this AMR. The Dr. Nura and the other doctor from Charitas Trust Hospital, and all our senior colleagues, junior colleagues that are on this very important webinar. We've been having a lot of conversation for few years now, with most time actually Professor Junaidu leading the conversation in different fora, and we're still having the problems. So as Femi said, we are here to I don't know whether we are going to get the blame. We are going to take, who will take the blame? The vets, the human medics, or you didn't bring the environmentalists, because One Health is about the human health, animal health, and environmental health. So maybe we should have also brought the environmental health people so that we all talk to ourselves. And at the end of the day, we can say, okay, yes, you are to blame, all of us are to blame. And then how do we actually bring this a solution to this big problem that we are having? So as Femi said, he has introduced me as the president of council. So I'm going to be talking from 2 points now. That is what it means. I'm going to be speaking from the point of a grandma who had experience of AMR, and also from the point of the president of the Veterinary Council of Nigeria. From the point of a grandma, I was actually, just like Femi said, I was meant to go for oath taking for veterinary students in the University of Jos. Shortly 2 days before the time, my grandson fell ill, and for 2 days he was running temperature, and he wasn't really eating well, and we all got worried. He's a very active boy. So first they said it was malaria, just like Dr. Babatunde, right? Is it Babatunde? Sorry, Femi, can you remind me, please?
Yes, Babatunde.
Okay, good. So what Dr. Babatunde said first was, because I just realized I've been worried also about this malaria and typhoid. It seems that malaria does not come these days without typhoid, or we're just assuming that typhoid might be part of it. But as he was running temperature, was taken to clinic, and now what they said is it was malaria. And they started treating him for malaria, but it wasn't really going. And his temperature kept going on and off, and so on and so on. We had to rush him to the hospital. So on reaching the hospital, they continued the treatment. Then his mouth was checked. The first day there was nothing actually, but by the second day, when they say it's malaria, you just finished malaria, and I will go. Unfortunately, by the time they checked his mouth, his throat was swollen, blisters, and it was almost it was bringing out pus. So they started on antibiotic treatment for 24. They say it was going to go on for at least 72 hours before we could go home. 24 hours, getting to 48 hours. I was actually meaning to say, oh, I can actually travel to Jos for the oath-taking ceremony. Unfortunately, by the time I came back in the evening, they said all the antibiotics that they have been using in the last 24 hours, getting to 48 hours, have not worked. And because they took a culture swab, and then they said the organism was actually resistant to all the antibiotics. You see, as vets, as human medics, sometimes, yes, we keep reading, and then we keep having conversation around that certain situations. They don't really get stuck until when you are confronted with the same problem. Then you know exactly how it is when you are faced with AMR. So I now really know that the problem is actually there. And before then, I was also talking to my own son, my nephew, my brother's son, and they told me exact story of what happened with his daughter, which he almost lost. And for us, it was much better because it happened while we were in the hospital. But when it happens when you're at home, it is not easy. When you see that the entire throat, child's throat is blocked, it is throwing up everything, and you are pumping antibiotics and it is not working. So the conversation must continue. We have to keep talking to ourselves. The One Health initiative has to continue, because from Professor Junaida's conversation, from Dr. Babatunde's contribution, and Dr. Nuruddin's contribution, we're all talking about the same thing. We're talking about contamination here and there. It could be from animal origin, it could be from anywhere. And so I'm sure also other people might have their own experiences, different experiences. Like Prof said, you can't treat a cancer patient because of resistance. You can't treat this case because of resistance. All the antibiotics are there. We have this bad culture. Apart from malaria and typhoid, our doctors too are not helping. Once you go, before you finish talking, they just put you on malaria and antibiotics. I think there is a lot that we need to do as professionals, to see how we can actually, from the veterinary side of it, as the president of council, yes, the veterinary council is the regulatory agency of the veterinary profession. We need to regulate the practice and the training of veterinary medicine, where a lot of our colleagues use antibiotic as a prophylaxis. I remember once you go to a farm, what you do, you deworm and then you give antibiotics to cover. You think there is stress, there will be secondary bacterial infection, you give antibiotics, whether there is need or there is no need. Because most of the time, for the misuse is that you don't really need antibiotic in the such cases like Dr. Babatunde said. When you have common cold and you know, of course, yes, the causative agent is viral, you still go ahead and say, when you ask the doctor why, you say, oh, you are giving it against secondary bacterial infection. So there is so much to be done in between the three components of the One Health, the veterinary component, this. And when we all know for the veterinary side that when you treat an animal, most of this, or virtually all the antibiotics, they come with withdrawal period. But I can tell you that that withdrawal period, whether from the side of the vet, you give it, you leave the farmer, because he's seen that he's losing his animal. Sometimes it's not like human practice, whereby when you see that your patient, your son, your wife, your daughter, or whatever is not responding, you start running to look for the doctor. Of course, you just want that person to survive. In the animal side, the farmer, once he sees his cow is going down, the next thing is, I don't want to lose. It's about money. Now it's not, yes, there are times that it has to do with emotions also, but in most cases, it's like, especially in large animal practice, in livestock. If it's a dog, most of them, there's so much emotion attached to having pets and so on and so forth. But for those that have, you are seeing your ram, you think that ram will fetch you like 70,000 if you sell it, or a bull or a cow, that you think it will cost it when you sell it is about 300,000, 350, especially now. Then you are seeing it lying down just simply because the vet came and gave it injection, antibiotics, and he has left, and you feel that you are likely going to lose that cow. So the next thing that comes to you is to salvage and at least get something. You just take your knife and call the butchers, just slaughter. And they'll just slaughter it, and they sell it to all of us, and we start consuming. That animal has just been treated with any type of antibiotic. They don't really care. So yes, the vets, we have our own issues, but the farmers, how do we, is there any legislation? As the president of council, yes, we can say do the right thing. You have done by giving the correct treatment. Even sometimes when you give the correct treatment, as you are doing the treatment, you say the antibiotic should go for 5 days, 7 days or so. But in the next 2 days, the farmer just decide, oh, there is no need to waste it, let us slaughter it. What do you do in that case? We don't have strong compensation mechanism whereby you say, okay, leave it, even if it dies, because you don't want to feed humans, and the man will not allow his cattle to die, and then he loses his money. So there is a lot, it's multifaceted, from us that administer, misuse, and so on. Even the farmer, when they see the animals are sick, they know, just like Prof said, everybody knows how to use TLA. The next thing is to take the TLA and give any antibiotic. They keep them at home as a normal working. They see every farmer, especially my brothers, the Fulanis, they know how to treat. They will make their own diagnosis and start treatment. And when the animal cannot make it, they just slaughter. They don't care about what happens to it. So it really, Femi, it is a difficult thing to say who to hold, whether it's the human medics or the animal medics or the environmental health guys. And then what about the farmers that indiscriminately use antibiotics for on their animals, and and just slaughter them for human consumption. I just saw Dr. Monde putting on something. I think he's one of the farmers that has declared that his farm is organic and he does not use any form of antibiotics in his poultry farm. And he markets it as such. Maybe when we go promote such things, maybe the poultry farmers will also look at it and we'll see how we reduce the use of antibiotics. Because routinely also, we also encourage the use of these antibiotics, all this biosecurity. Yes, touching this, giving antibiotics. Or when you debeak, the animal is under stress. The next thing you do is give antibiotics to stop them from falling ill. So there are so many complicated issues, and then the eggs that have these antibiotics end up in our mouth and the mouth of our mouth and those of our children, our families. There are also contamination from all this. But I think it's really, really multifaceted. We can't just pin down and say this is the person that that is at fault, whether it is the vet or the human being. I think we just have to find a way to sit on the table and do a lot of, because when I saw that illustration by Prof that he presented on how to handle from sensitization and so on and so forth, it is everybody's business. I'm just trying to look at it because from regulations, that's where the council falls in, regulating the use by veterinarians for us in the veterinary regulatory agency and other regulatory agencies. Then professional competencies, that where we are also going to look at ourselves. How competent are we? How responsibly are we using antibiotics on our patients generally? And then the issue of awareness. The awareness comes where the farmers are also involved, public engagement, consumer demand. So we also sensitize the public, like other people are marketing that they are using zero antibiotics. Let us encourage that, unless if it is extremely important that we use antibiotics before we do that. I'm happy that I've just seen Dr. Gani, a participant of the Senior Executive Course 45, also joining us, because I know he too has been doing a lot of work on this antibiotic resistance. So basically, this is just from the point of a grandma and the point of the president of council. That's what I want to say, but I'm ready to go on stage with other colleagues so that we can actually see who to blame in this case. Thank you very much. Femi, are you still there?
Yes. Backstage, can you bring me up? All right. So thank you so much, Madam Capacity, for this brief. I want you to help us bring up Dr. Tumsia and also Professor Junaidu, so that we can take a few questions and let's interact together. So I'm going to ask the first question to Professor Junaidu. So do we have any data linking what we do on farms and the AMR we see in humans? Is there any concrete data? Because sometimes the challenge is we know that there's a problem, and that problem, we speculate around where the problem is coming from. So when I asked the human medics, they said it's probably because people prescribe indiscriminately antibiotics. I'm not sure I got this sense that what we do on the farm could actually be a strong link. Maybe it's the awareness that is not very strong. Is there a link between what we do on the farm so that we can come back to the president? And because she's in charge of all vets, I feel strongly that there's a link between the eggs my children eat and the antimicrobial residue, because children are young. They are super young. If an adult of 40, 50 years old has an antimicrobial resistant issue, I can understand. But children, less than a year.
1 year. Under a year, yeah.
Should we be worried, Prof?
I think there's sufficient data to make us worried. And this data is not even recent. I don't know, can you hear me?
Yes, we can hear you, Prof. Go ahead.
Okay, this data is not recent. Like I said during my presentation, some of these debates started first in the United Kingdom in the 60s. whether there is a connection between use of antimicrobials in animals and the transfer of resistant pathogens from the animals to humans. And this was proven in the 60s and late 60s and early 70s, even before molecular methods became advanced. Now, with advances in molecular methods, there have been tons and tons of evidence, like even in here in Nigeria, where there is a connection between the animal pathogens and the human pathogens that are seen in contact humans. So that is not reputable. It is established, and there is a lot of information out there in literature to show you the evidences. Now, in terms of residues, uh, the drug can't get to the animal unless somebody puts it there. So it is what we use that ends up in the product, because the drug is not natural to the body. It will have to be removed. So the animal product that we consume are only one of the pathways the animal tries to get rid of the drug from its body. So you can find it in egg. Anything that circulates in the plasma, the proteins come from egg, from the plasma, the proteins that are used to form the egg. Most of the things in milk get filtered in the serum, also in the plasma, gets filtered into the milk. So once we use drugs, the animal products are bound to carry the residues. And the most important strategy is we don't use drugs, your food products are safe from residues. And like I said, the connection between the use of antimicrobials exerting selection pressure in the emergence of pathogens is everywhere. There's tons of literature on that.
Thank you so much, Prof. Okay, is it still on?
Yeah, I'm here.
All right, okay, so let me get to the president and then I'll come back to you shortly, if you can all hear me. Ma'am, somebody, a vet, a qualified vet, I don't know whether we should take his license or not. He said that he was bragging to me that human drugs work best nowadays, that he doesn't use animal drug preparation again, that it's best he uses the human preparation, that works better. First of all, as the president of the council regulating our practice, what's your thought about this? And should we seize the person's license?
Well, you are also a council member, Dr. Femi. So the president does not take decision alone in council. And usually there's a process for the withdrawal of license or any form of punishment. First and foremost, you see, it's like you are sitting as a policeman, you see crimes are being committed. But sometimes if you don't see it, you didn't see it. It's a responsibility of the public. Like now you are a council member, you are a vet. If we know such cases, it should be reported to council. In the council, we have the council investigating committee. So there are steps. It goes to the investigating committee, and the issue is being investigated. If it needs to go to the tribunal, veterinary tribunal, it goes to the tribunal. And if the person is found guilty, then we set the punishment. If the punishment is withdrawal of his license, definitely it will be done. Definitely. So if there's any professional misconduct, the council is at liberty to deal with such cases and also award this. Yeah. So if you know such cases, or if you know such a case, it will be nice for you to bring it forward, because I'm just hearing it for the first time from you on this platform. So you shouldn't keep it to yourself, because it is also a responsibility of you. You are a board member, and you shouldn't keep such very dangerous information to yourself.
My intention was to put you on the hot seat. I didn't want it to be reversed, but guess I miscalculated.
I think you did.
But it's fine, Madam President. All right, so to Professor Junaidu quickly, and Dr. Tumsia, you can get ready your questions after this. You just take over, and then we can end the meeting. But to Professor Junaidu, Right. So we don't, and maybe probably to also the president, once you give a thought, one of the reasons why vets don't really quarrel farmers is because we don't pay compensations for eggs for withdrawal periods.
Yeah.
Right. What do you think can be done, Prof? And then maybe the president can also come in from the policy angle. Because withdrawal simply means that if you're using some certain antibiotics, you should throw away those eggs. Right? I'm not sure. In my 15 years of practice, I've seen any farmer says he's observing withdrawal period, so these eggs are condemned. I don't know if anyone has seen them. You can comment on the comment box. If you have seen the farmer said the eggs for the next 7 days will be thrown away because we're observing withdrawal period. That even sounds very strange. So what can we do to observe this? And then from the policy angle, we'll get to the president. How can we resolve this?
Sorry,
Is it
the network went.
Okay, no, first to Professor Junaidu. We don't observe withdrawal periods. What do you think can be done to enhance veterinarians in observing this?
Is it me you want to answer, or is it Prof?
No, first to Prof, then you now come in from the policy angle, but first to Prof.
Okay.
I'm not sure if you got my question properly.
I didn't get it properly.
Yes, veterinarians and farmers generally don't observe withdrawal periods.
Yes.
So from the academic point of view, Professor Junaidu, except if it's off, what do you think we can do as a country to get us to start observing these stipulated standards? And then to the president, from the policy angle, how can we encourage governments to weigh into things like this?
Can you with me?
Yes, we can hear you now.
Hear me?
Yes, we can hear you now.
Sorry, the network is interested in embarrassing me anytime I'm going to talk. So, my personal experience is it may interest you. It's actually among the Fulanis that I actually saw the compliance to withdrawal period. Strangely, quite a number of communities, if we tell them that, look, don't drink this milk because of this problem and this problem, I've seen about 3 different occasions where they complied. In one particular occasion, the community leader called everybody. I mean, all the household, the head of the households, and he said I should tell them what I want them to do, and I did. And I was so surprised. I mean, eventually he told me he has a grandmother, very elderly, who only drinks milk. So he is not interested in giving her anything that will harm her. So he took the advisory very seriously. Now, about poultry eggs is a slightly different issue. You're absolutely right. I can remember seeing a farmer that threw away the eggs within the withdrawal period. But I've seen a farmer that delayed broilers from going to the market to observe withdrawal period. Now, there is some economic reality here. It far goes beyond science. And that is why the public education, the awareness campaign I was talking about, is something very strategic. You know, the WHO FAO OIE strategy for AMR involves 5 pillars, which is surveillance, infection prevention, control, stewardship, awareness, and research. If you read all the document, it looks like all these pillars have the same size and strength or importance. But I think the biggest pillar for us that we need to use if we want to solve this problem is awareness. We have a big responsibility of giving people this information. There are people that by nature have conscience and they are willing to do the correct thing even if they are going to lose money. There are some people, of course, that if they are going to lose money, they are ready to commit murder. So they may not necessarily comply with withdrawal period. But overall, the first obligation on our day step is to educate people. First, let's not think they will not comply. Educate people. And education is about strategy. How do they stop people from smoking? It's addictive, it's fashionable, but it was stopped to a large extent. So it is a question of we professionals are not the only communicators. Deploying the right resources, human and material, to deliver the information to the right audience and to educate people that, look, some of these things in the long run are harmful to you. Let me give you an example. When nitrofurands were banned, we keep telling people, don't use these drugs, don't use these drugs. But they use them because they are cheap and they're effective against salmonella in poultry. They're still effective. Resistance to nitrofurands developed slowly. But farmers were not willing to listen. Then we found a back door. We realized if you use nitrofurands for some time, it will affect the production of your birds. Now, if you combine the economic story and the public health story, we can tell people, look, this drug will affect the productivity of your chickens. It also has a consequence. The first message will lay foundation for the second message. But like I said, I'm not a communication expert, but it's a question of really communicating the information correctly and in a way that people will see the importance of the message. We have a lot of work to do. Many people are not observing the drought period.
I agree, Prof. So let the president come in. Do we enact policy? Prof has come in from the angle of education, and that's absolutely very correct. Sometimes we assume farmers will not observe it, but if we tell them what the issues are and why they need to, they might comply. Can we combine it with effective policy, Madam President?
Thank you very much. Of course, yes. Effective policy. I like the way you use effective. You see, when you make policy that you cannot effectively implement, it's a problem. And that's what where Prof was talking about, the economic component of it. You make policy where, because when you, for instance, I remember even when we were young vets, we used to go, not vets, in fact, veterinary students at that time, even when we were doing attachment, sometimes your attachment, you go to abattoirs and so on and so forth. And when you do meat inspection, Prof is in public health, he knows what I'm talking about. You go and do meat inspection, and you find that you either need to do a total condemnation or partial. Even the partial ones, you say maybe the lungs, you have seen some miliary lesions or some whether that you think, or the liver is infested or something like that, and you need to say you have condemned this organ or this organs or this part of the carcass against food. You end up having problem because the law says yes, you condemn, but when you condemn, what do? You also compensate. So we can go ahead and do law, but if you cannot implement, you have just become like a toothless bulldog. You keep barking and you say there's no, and then how do you compensate? Like you talk about this poultry. Let's say a farmer that is producing 100 crates of eggs per day, and those 100 crates of eggs, they have not passed through the withdrawal period. You have just treated the birds with, so you and you have a policy that says you must comply with this. So how do you compensate the farmer? Do you tell him to be throwing away 100 crates of eggs and he's going to be feeding the eggs? It might not be that much. I was just, as Prof was talking, I was trying to do some little calculation, and we looked at it. Let's say even if it's at that time when it was just 1,500 a crate of egg, let's say 100 eggs is 150. By the time you do, let's say 10 days withdrawal period, we're talking about 1.5 million. Actually, it's not that much to say you cannot compensate, the government cannot compensate the farmer. But how many of such farms? So we look at it from different angles. Sometimes it is not just, you cannot make laws that or policy, you cannot bring up policy that because policy is about responsibility also. There is a responsibility of the formulator of that policy, and also responsibility from the people that are also complying. You say you will do something. If you do this, then how is it that government cannot compensate? What happens to the farmer? So as I said again, it is multifaceted. There has to be political will. We look at it, we have to make community engagement, both the policy makers themselves, the government, let them understand. Because first and foremost is understanding the danger AMR. And sometimes we also learn from lessons, difficult lessons. I just gave an example of my own personal experience of a child that was just below 1 year that had AMR. At that particular moment, I'm sure if you are faced to cite a policy that do this, it will stop AMR. So when you experience things, you understand exactly how it feels. So I think we really need to communicate more. We really have to say, before you come up with that policy, is that the Prof said is awareness, public engagement, not just public, government, engage with government. This conversation that we're having, the human medics, the veterinary component, the animal health, environmental health people, and every other person, and we bring people to share experiences on national television everywhere. What has happened. If we have typical cases of AMR, let us show it. Let us show. So let us come with a policy. How do we, if it's a vet, okay, you don't use, maybe you come to a poultry farm. When we have avian influenza, when they know that it's affecting, they were calling it, but then even that one, they were having issues. That in that situation, they couldn't pay the compensation to farmers. So veterinary council, yes, we can come. Policies just sit down and we call people like Prof that are so experienced. We'll come and draft and come up with a national policy on the use of antimicrobial in animal. Or if you do, you must. We say you must obey the withdrawal period. Okay, when you obey it, you have 10 crates of eggs. Like Prof said, for broilers, you can delay them going. Of course, it's also that one is an additional cost, because if you delay going to the market to sell your broilers for the next 10 days, if the withdrawal period is 10 days, 14 days, for instance, if you delay your birds going to market for 14 days, now with the price of feeds, who feeds those birds for the next 10 to 14 days? And when you keep them, it means that you need to sell much more than that, otherwise you're going to. So there are so much. I said somebody said alternative is simply vaccination and biosecurity to stop those pathogens from the point of entry. I just saw somebody putting it on the platform. There are a lot of things. Maybe we need to engage, public engagement, consumer demand, of course, yes, personal hygiene and so on, and even environmental protection. We need to look at ways where we will also, so that when you minimize, because when the exposure factors are many and you have so many farms engaged in that, how will you compensate? But when you drastically reduce the number of or stop the pathogens, like we say, of course there will be breakage somehow. When we strengthen the biosecurity, maybe very few farms that we can manage the compensation comes. When you see government commitment in terms of protecting these farms and making sure that they don't fall ill, that you don't need to use antibiotics and so on, in those few cases that happens, you'll be able to handle them. But otherwise, council can sit and make laws that you cannot implement, laws that does not make sense. You see, that's the problem of Nigeria. Too many laws without enforcement. And at the end of the day, you ridicule yourself as well. So we have to look at it from the guys like a symptomatic treatment. But council cannot go and be destroying somebody's 100, 300 crates of eggs, and then for 10 days you're talking about 100 times 10 is about 300. You understand? So it is beyond it is beyond just policy. That's my own take.
Thank you, Madam Capacity. Well, we can keep this conversation going and going and going, and it will not end. You know, I saw a few quotes, first from Dr. Monday, that, you know, some actions, they said he who throws stones must also remember that if you live in glass house, you cannot afford to do that, right? Some things you do can turn around to hurt you because we are all living in the same ecosystem. I want to, backstage, you can bring up Dr. Tumsia while I state this quote for her to ask her last questions and then thank
Yeah,
our...
sorry, I just want to add, I saw something from this. I'm just very interested in this cycle, this diagram that Prof shared. That's what I'm actually looking at. And it's talked about regulation, use guidelines, maybe guidelines to farmers, guidelines to veterinarians, and so on and so forth. Rather than saying we're going to put in policies that will be difficult for you to implement.
All right, so that's noted. Somebody said, in addition to that, somebody said, if you use antibiotics when you don't need them, you will not be able to use them when you need them, right? And I saw that quote online. If it's not needed, you don't need to use them. Prof, the way you taught us, now a day-old chicks farm, maybe probably a farm that just recently installed day-old chicks, they use antibiotics all through, and that's alarming. And I want to encourage every one of us, while I hand over to Dr. Tumsia, if you don't have to use them, you shouldn't use them, so that when the time comes and you need them, then you will have them to use. Dr. Tumsia, please, over to you.
At least not for prophylaxis. Let us not use, especially not for prophylaxis, really, because that is where the abuse comes in. Because people use it for prophylaxis. Oh, let us just cover it with antibiotics. Yes, go ahead.
Dr. Tumsia.
Okay, thank you very much. I have just a million and one things have been going through my mind as the president of the council spoke, and then also Professor Jinedu. And I remember asking myself, while I was still a field veterinarian, there are a few hatcheries that actually send out their birds with antibiotic prescription, right? And I asked myself, if you know that there is need for these birds to take antibiotics at the point of exit from your hatchery, then why don't you go back and do the right thing? Why are those birds transported in those dirty-looking buses and handled by people who know nothing about it? So why is there no attempt to make sure that the birds, because I have met farmers who will tell you their birds are coming day 3, and then you open the birds, day 5, day 7, you open the birds, and then you will see polio. And you clearly can tell that these birds came with it from the hatchery. So we talk about policies, and then the president talked about implementation. So policies without implementation is nothing. So for me, I strongly believe that we need to invest more in education and awareness. In Nigeria, we try to force down policies on people. We try to force down laws on people without getting them to understand. So I'm currently having this meeting in my mom's office, and she heard the part where the doctor said people treat malaria and typhoid all at the same time. And she just put her hand on the head. She said it in house, and she said, "Oh, why are they always giving us antibiotics if there is no need for?" Right? She was so stressed last week, and she said she has typhoid. I said, "You don't have typhoid. You are just tired. Go and sleep." You know, she slept for like 2 days and rested. She woke up, she was like, "Hi," and it worked. So I just feel that there is a lot of gap between what these people need to know and what we know. We are concerned about this problem, but I'm not sure we're trickling down this information. Look at the example Prof gave about the Fulani man who has an aged mother who takes milk, and then Prof enlightened them on antimicrobial residues in milk, and he said there is no way he would give his mother something that harmful. For me, I would say I've listened to radio, but I have not heard on weekly basis where we are coming up as antimicrobial stewards to enlighten the public on the harm of antibiotics, right? We know it, but I'm not sure the people who constitute part of this menace know the impact of their actions. So for me, I would just say the policies are good, yes, but we should invest more in awareness and advocacy. For me, that's just, there's a lot of gap. There's a lot of knowledge gap. That's just what Because Dr. Moses said something about conscious. Yes, there are a lot of people who are conscious. And if you tell them this is how they do it, but most of them are doing it not knowing the impact of why they're doing it, the impact of what they're doing. So thank you, everyone. I can see a lot of questions coming in. Dr. Gani is also sending in some of his comments. He said there must be some carrot and stick approach. After sensitization and education, the live bird market, if raided, would have tons of antibiotics powders daily, but daily in water, ad libitum for on sale. So these birds are even on antibiotics. You will come and you will point it and you will pick it up right from the cage and sell it to you. We have Ibrahim Ahmed from Liberia, and he said, here in our small way, we do the following. So let me read out. Comprehensive AMR situational analysis, AMR stewardship program for both animal health and I don't know what PH workers, I don't know what that means. Developed treatment guidelines for AH, I don't know if it's animal health. Farm biosecurity guidelines, develop an integrated AMR surveillance guidelines and system, encourage government to deal with the issue of importation and distribution of drugs, fake drugs and smuggling. Somebody made mention that most of us are sales reps for these companies, and the bottom line is that we just need to sell. We're given a target, whether it's these animals need it or not. You will see sales reps going to farms and supplying them cartons of antibiotics. Like, this is something I have seen. And I asked the guy who brought it, I said, why are you bringing this? He said they're expecting 20,000 birds and they will need antibiotics. I'm like, you've not even seen the birds. You've not done anything, and you just know that they will need this amount of antibiotics. So I think we need to check our activities also as veterinarians. I'm not sure we need to blame anybody. Let us be mindful and be conscious of your actions. Thank you very much. I don't know if Dr. Kayode, I've not seen any question other than the ones you've answered. Okay, Ibrahim Ahmed said animal health and public health sectors. Okay, thank you for that clarification. Somebody is saying, do we even have vet doctors to go around the farms in the country? And I would allow the president to answer that. Ma, do you think we have enough vets to go around to attend to all the farms in Nigeria? I can hear you. We can hear you.
Oh, is that a question for me?
Yes. Somebody is asking that. Do we
Definitely,
have enough vets?
Definitely, we don't have enough vets. With some state having just one veterinarian in their services, maybe two, some state governments, definitely we don't have enough, both government vets and then private vets, because the vets, the population of vets, we have less than 10,000 veterinarians. That is the entire register for veterinarians, and some have are not practicing, some are in government where they are not doing. Do you understand? So the number of veterinarians that are actually providing the services, of course, yes, are not enough, definitely.
Okay, so Ma, what are your thoughts, and what do you think, what can we do to jack up this number to make sure that we have enough veterinarians to go around? Do you think having enough veterinarians would actually mitigate this problem?
Really, it's not just about having a number. It's not a number. The answer is not just in the number. There are so many like with multifaceted problem. Even if we have veterinarian to each person, if we're not doing the right thing, if there is misuse of antibiotics, that has nothing to do with number. It is not because there are too many vets or less vets that we're talking about. Misuse of antibiotics or overuse, or where it is, you understand, so many other. So it's actually not it has nothing to do with the number of veterinarians. But in our own part as a council also, to increase the number of veterinarians is part of our roadmaps. It's part of the agendas for this council to increase the number of veterinarians, and we are going to go aggressive. We have started engaging some state governments on advocacy, telling them that there is need, because our standard, that what we have, the minimum standard is to have at least minimum of 2 veterinarians per local government. That's on government side. We should have at least a veterinary. When I was growing up in my town, everywhere, every local government, you see that they have a veterinary clinic, government veterinary clinic. But everything is also not about government, it's also complementing with the private practitioners. Like Famala, they are doing well. Down Rover, there are a lot of private veterinary outfits out there. So the actual problem is not about the number of veterinarians. It's about responsible use of antibiotics. That is
Okay,
what we're talking about.
okay. Yes, ma'am, because we cannot completely rule out with industrial livestock farming, we cannot completely rule out the use of antibiotics, so we can as well advocate for responsible use.
Responsible use of antibiotics. We cannot say don't use antibiotics, but let it be responsible.
Yes, sir. Yes, ma'am. So somebody was saying that how is it something that is achievable to have veterinarians regulate the sales of veterinary drugs and biologicals? I know we've been going back and forth on this particular matter regarding the sales of veterinary drugs and also other biologicals. What do you think? Do you think that would also help? And do you think it's something we should have in place?
Yes, I believe veterinarians should be able to practice, but we are also talking to our veterinary schools. You see, most of their Tambor Prof is the Dean of the Faculty of Veterinary Medicine, ABU Zaria. We are looking at situations whereby the veterinary schools shouldn't just focus like a 1 degree awarding faculties. Most of them is just DVM. When there is gap, of course, other people will follow up. You know, you don't create gap and don't expect people to fill it up. So we should not be focusing on the Faculty of Veterinary Medicine should not be focusing on a 1 degree awarding institution. We can run veterinary pharmacy degree. We can run. There are a lot of courses that we can do to fill up the gap. But it's because we are just focusing on DVM. That's the only thing we are doing. That is why even now faculties of pharmaceutical sciences, they are now running veterinary pharmacy as a course, which is not supposed to be. So we have a lot of things, even we on our side. You see, I keep telling people, as a profession, that is why we also need this, all the relevant stakeholders in the animal health sector to be able to find a way, common ground, where we develop a standard operating procedure for all the professionals in the animal health sector. When you look at the human medic, I keep giving them an example. When you walk into a human hospital, after the gate, once you get to the registry, before you leave the hospital, depending on your case, you must have seen 6 different professional bodies, from the animal record people, from the animal record people, they call that animal records professionals, to the nurses, to the pharmacists, to the laboratory scientists. Even we are not even focusing on our own veterinary laboratory science. Sometimes we resort into taking the human medical laboratory scientists. So we should be able to have a robust animal health care system. Because when you go to some of these clinics, you see that it is the vet. The vet will be the one taking the record. The vet will be the one managing wound. The vet is the one giving injection. So these are the kind of things you overwhelm yourself by the things that you are not actually trained. When you go outside this country, go to, let's say, to the UK, you walk into a veterinary hospital, you meet that somebody will proudly tell you, oh, I'm a veterinary nurse. And the veterinary disease, we have one regulatory agency. We focus on training different people in different sectors. So, but we are too rigid. Everything is about DVM. I keep saying, even our vet, you'll be the one when you are doing surgery, is the vet that is shaving. How about, where do you see doctor shaving? So we should be able to delegate and expand this animal health sector so that everybody will feel carried around. Even for us, the regulation is giving us a lot of say. We are going to soon organize a stakeholder meeting where we are going to have all the stakeholders in the animal health industry. So we sit down and say, okay, hey, how do we have a standard operating procedure for the entire animal health system? Everybody knows his boundaries. And then our deans should also start thinking about coming up with other courses out of DVM, not just DVM. Because I saw when I can see that Prof agrees with me when I saw him do like this with his head. So I believe he also understands he believes in what I'm saying. I think those are the areas that we should look at.
Okay, ma'am. Thank you very much. This is a marketing question. Someone is saying because we named these big pharma companies, veterinary pharma companies, as one of the problems because, of course, they have their sales reps who need to sell these drugs regardless of the situation. So someone is saying, how do we inform the marketing strategies for big pharma companies? Because these
How do
are,
we?
how do we inform marketing strategies? I know it's not in your place, but the person is just trying to say, I'm sure, that these marketing companies come into Nigeria and they sell drugs. I'm not sure anybody stops them at any point to say, these are your boundaries, this is what you need to do. They just give them NAFDAC licenses them, and then I don't know if it's the Federal Ministry of Agriculture or the council, I don't know who does the other thing. But then they come in and then they just go into the market and then they start selling. So I think what the person is saying, that there is need for proper information. These people need to be properly informed. So I don't know, yes, as I said, maybe NAFDAC, we have our colleagues in NAFDAC. I'm not sure if that that process is being done when we have new drugs and biologicals introduced into the country. We've spent way over 2 hours. It's not, I'm sure.
Let me say something before you go. Before we go to Sia. You see, when you said this, it really brought back a lot of things into my head. A lot of these companies, I agree. When they come, they say the first point of call is the Ministry of Agriculture, which is okay. The Veterinary Council, they come with all sorts of incentive. Oh, we are coming to develop, to support you, to build laboratories. Oh, we are coming to support you with capacity building. When they underline this capacity building is actually all about their drugs. Once they get ground, there was a time when Zoetis came, I had issues with them. They will come and they are flaunting the whole market. They carry veterinarian, and the same veterinarians that that you take, that they market them. They show like they have come to support us, but in the real sense, they have come and they come in without following any regulation at all. So I think really between the Ministry of Agriculture, that's the department, and the council, we really need to sit ahead and see which companies come in with drugs, what do they want, what kind of drugs is it that we have, and we should also be able to monitor how they market. Because responsible marketing will also result in responsible use of antibiotics. Because if we regulate how they even market, what they tell these farmers, the uses of these drugs, and so on and so forth, then we will have almost solved 50% of the problem. I remember, as I said, when Zoetis came, it was like, oh, Zoetis have come to solve Nigeria's problem in livestock. But all they did was just for them to introduce their drugs, and once it is accepted, you never see their faces. So we really need to be intentional about who comes in here with what, not about NAFDAC. NAFDAC cannot, if NAFDAC gives them license, does not mean that they can just come into the veterinary space and do whatever they want to do without guidelines, without recourse to the regulatory agency for the profession. So thank you. That's what I wanted to add. Thank you.
Okay, thank you very much. Someone here is saying that marketing is actually supported by sponsored research, justifying uptake. So what this person, if I understand what you're saying, is that these companies have made their research and they're justifying their sales, right? So I'm not sure. I don't know if there is any platform or where these companies get this information, or do they push out anybody?
To be honest, I don't even know whether there's any. Most of these drugs that they bring in. Yes, of course they do. The drugs have been certified, and then NAFDAC said. And then, is there anywhere that we have done any in collaboration with some of these faculties of veterinary medicine to see how we can do drug trials within this country? I mean, in terms of Nigeria, instead of the drug trials, that the drug is okay in the US, it's okay in Europe, and so on and so forth, and they come and get a license to come and do we insist on having drug trials on this drug that they are bringing to say, okay, specifically, is it okay in Nigeria also? Rather than accepting it's our veterinarians. They come when they give us. We are in private practice. Okay, yes, we are going to sponsor training. We are going to sponsor this, and then they keep us in a hotel for 2 to 3 days. You know, we have tea break and we have lunch and this and so on. And then the next thing, we are selling their products. I think there's a culture we really need to look at and see how we change that attitude.
All right. Thank you very much, Ma, for that. I like the way this conversation was able to scratch off some of these things that needed to be said. And I think we need to all go back to our various locations. We can go back home and reflect on what roles we're playing and how we're contributing to this menace. I want to call on Dr. Kayode. Dr. Kayode, are you still here with us? Because I think every other thing coming up are comments. Is Dr. Kayode still here? Let me read out this last comment. Abimbola Oluwalo Banjo is saying, let me give you another example. I collected broilers from 3 different hatcheries at 3 different times. I traveled to a vet lab in another state to do sero monitoring of the DOC. The lab/vet doctor gave me some medication and vaccination for the 3 different sets. Is it possible? Yes, you collected. I don't know. I don't want to answer this, but you said you collected them from different hatcheries, so you should expect that different things will come up. They were hatched by different breeders, so you're not expecting. Even what we keep telling people is that the benefit of the use of DOC is that even if these birds are laid by the same bird, they are laid at different times, right? And you don't expect the same amount of maternal antibody to be transferred to the DOC in the same quantity at all points, right? So that's why there is need. So if there is any disparity in their source, then you would expect some slight differences in the result. All right, Dr. Kayode. I think
All right.
my own end.
Well,
Yes, sir.
thank you so much. I was hoping you will wrap up the meeting. So for everybody who is
I will wrap up, but I was thinking if you had 1 or 2 things to add before I just finally call it a day.
No, it's to first of all thank the president of the Veterinary Council, right? So we like to call our president of the Veterinary Council, but we also like to add the AIG because she occupies a very unique role in both offering advice and also punishing when the advice is not well taken. So she's always a delight when she comes up on our show. But I think the brilliance in which she brings to conversation is what amazes me. And this is us from Farmalat saying thank you for being almost always available for every of our program. This is to warn every veterinarian listening. If you misuse antibiotics, we will put in the Veterinary Council law also that you will be arrested with the permission of the president. But that's on a lighter note. If you don't need it, you don't have to use it. Some of us have children, and I'm honestly worried that we don't get to that point where we see them go down without knowing what to do. And it starts from us. And to Professor Junaidu, thank you so very much. You lectured us 15, 20 years ago. You're still lecturing us now. It's because we find you valuable at every point in time. Well, I will leave you, Dr. Tunsia, to do the thanks and then to do the closing remark. Madam Capacity,
Okay.
thank you so much.
All right, thank you very much, everyone. Ms. AIG Aisha Tubaju, thank you very much, ma'am. Professor Junaidu, and the human medic doctors we had on. Thank you so much for your contribution. The back end, if you can hear me, can we have the screen up? We'll round up in 5 minutes or less. Okay, just keep moving and just a few announcements and then we'll call it a day. You keep going forward. Yep. No, as in I'm saying just yes. Towards the tail end. Just keep moving. Once it's good, I'll let you know. Keep going. All right, next slide. All right, next slide. So thank you very much. As you all know, we serve as a private CE provider to the Veterinary Council. So these sessions are accredited as continuing education programs and Farmalat awards certificates for attendance. Of course, Attending the sessions are free. However, next slide, please. If you need a certificate, you will pay a sum of 2,750 naira. Next slide, please. All right, so you will pay a token of 2,750 naira to get your VCN accreditation and certificate from Pharmalat. So just follow the steps. Make payment into Pharmalat Echo 7901049-235 Providence Bank using your VCN number in the description. And then send a message to Dr. Tumsia on 0813-863-4476 for verification and for your certificate. So once you make payment via this WhatsApp number, send your name, how you want your name to appear on the certificate, your email address, and of course your VCN number, and then your proof of transfer. Thank you so much, everyone. Next slide. So if there are other topics you would want us to address, you can also send me a message via that same number, and we'll use it to inform our choices of topics going forward. Next slide. So thank you so much once again, and please follow us on all our social media platforms, YouTube, LinkedIn, Facebook, Instagram, just to stay updated with all of our activities. Simply search Pharmalat and you'll have us up. Thank you once again. Enjoy the rest of your day. Stay blessed, and bye.
Human beings assume we're the only people on Earth. Unfortunately, we aren't. There are millions of species on the surface of Earth. And most of the times, we make these decisions without even thinking of how these decisions we make affect every other thing in the ecosystem. My name is Tumsia Maimunaman Isa. I'm a veterinary doctor and an active field worker. AMR, this might sound new to a lot of people, but this is the looming pandemic that is about to hit, antimicrobial resistance. Have we wondered why we take drugs that we used to use years back and we quickly get better and we're back home? And then now you're using these drugs and they're not working. Some people will say NAFDAC are no longer doing their jobs. Some will say some of our brothers are producing substandard drugs. I'm not completely ruling out all those things, but have you asked yourself how you are contributing to this menace? So antimicrobial resistance basically means that the antimicrobials that are causing diseases, the bacteria, the fungi, the parasites, are now becoming resistant. And I like to use this phrase: what does not kill you makes you stronger. As a veterinarian, I will be speaking, of course, from the One Health approach, but mainly I will be speaking from the angle of the animal health. So most of our farmers are contributing immensely to this problem by misuse, underuse, and overuse of antibiotics. So these antibiotics have been produced, or should I say have been manufactured, to be used at a certain quantity over a certain period of time and for a specific reason. But unfortunately, here in Nigeria, a lot of poultry farmers are guilty of antibiotics abuse. For the slightest problem that is avoidable, they use antibiotics. Not just use it, they overuse it and they underuse it. As a veterinarian, this is a very concerning problem. Research in Nigeria has shown that most Nigerians are at the risk of consuming edible products, edible poultry products, fish products, other livestock products that contain high amounts of antimicrobial residue. And when I say high amount, we're talking about over 64% of this edible product contain antimicrobial residues. Scientists in Nigeria took the pain to conduct research just to prove and have a substantive evidence that these antimicrobial residues are present in poultry byproducts and other livestock products. Ekene Vivian Ezenduka in her research found a 64% prevalence rate
of antimicrobial residues in poultry edible byproducts in Enugu metropolis. Jalaluddin Rabbana Lawal et al., in his research of antimicrobial residues as a potential public health hazard, found that a large populace of Nigerians are at a high risk of consuming edible poultry byproducts with antimicrobial residues in them. Let's listen to a story of someone who found out that an antibiotics wasn't working for her.
Hello, my name is Precious, and this is my AMR story. So I think in October, I got sick, and then I just went to the clinic. I think it was, my sister was scared I was actually was, so when we got to the clinic, we just had malaria injection and then typhoid medicine. So I started taking the typhoid, the antibiotic, and then it was looking as if I was not getting better, because I was supposed to take in the morning and in the evening, but I just wasn't getting better. My head was still aching. I could not really stand properly, so I had to take a break. I was advised to take a break, and then I started taking 1-1. I think about 2 weeks ago, I think a week ago, I felt sick again, and this was I think barely 2 weeks after I'd finished my medication. So I just went to the hospital, did a blood count, and then it was said that my typhoid was very high, like 160. And I'd already taken antibiotics, so I think it wasn't, my body was not accepting that one. It was rejecting it. So what the doctor did was to give me Ciprotab, IV. So I had to take in the morning and in the evening for 2 days. And I'm better. There was no culture done because I already had an antibiotic in my system already. So I think I should actually go for a sensitivity test to be very sure of the antibiotic I should take next time. So I think it was partly my fault because I didn't really go into all the details and then do what I was supposed to do. So, but now that I know better, I know that my body can actually reject antibiotics. I don't know the cost, but I'll have to do a sensitivity test to know the one that works for me. And honestly, there is a antibiotic test that we can do, a sensitivity test that we can all do to know the antibiotic that works for each and every one of us. I will do mine, so please do yours. Thank you.
My dear animal owners, my dear farmers, do you know that you can reduce the use of antibiotics on your animals by adhering to strict sanitary and good hygienic practices? Giving clean and safe water to your animals, making sure the environment is clean, making sure their feed is free from microbes. Stay safe, stay clean, stay healthy.
Are you in Lagos, Ibadan, Kaduna, Niger, or Abuja? Then this is for you. Farmalart, in conjunction with Ashoka and Kasha, present a national-wide campaign on the antimicrobial resistance and the importance of clean and safe drinking waters on farms. Yes, the dates are Niger 18th of November, Lagos 21st of November, Ibadan 23rd of November, Kaduna 25th of November, and lastly Abuja 29th of November. So pick a date and make sure you're there. See you there. Bye bye.